Hello, welcome to your online lecture for the course Pathophysiology 2. In today's lecture, we're covering skin tumors in both benign and malignant form. Before we actually start the lecture, I would like you to take just a few minutes and watch the video that's provided to you within your PowerPoint. If you can't access it directly there, you can use the YouTube link. I would like you to spend a few moments watching this video because of its relevance. It's a very powerful and emotional short video. So let's have a look at skin tumors and let's break them down into benign and malignant form. Most benign tumors of the skin are associated with aging, and some examples include seborrheic keratosis, actinic keratosis, keratoacanthoma, and nevi. Malignant tumors of the skin have the ability to spread and or invade other tissues in the body, as we know any malignant tumor can do, and it can be deadly. So malignant skin tumors can be deadly, and if they aren't deadly, they can be very disfiguring. Basal cell carcinoma and squamous cell carcinoma are collectively known as non-melanoma, and they are the most prevalent forms of skin cancer. Malignant melanoma is the most serious and the most common cause of death from skin cancer. Chronic UV radiation causes most skin cancers, so protection from the sun and avoidance of tanning beds, especially in children, significantly reduces the chances of skin cancer in later years. So protecting your skin from the sun is so important. Lesions are most commonly found on the face, the neck, the hands, and other areas that are exposed to the intense sunlight when we talk about malignant tumors. And so we have to protect these areas with wearing hats and sunscreen and appropriate clothing in order to reduce the chance of developing skin cancer. Genetic mutations in both oncogenes and tumor suppressor genes are also associated with skin cancer, and we talked about oncogenes and tumor suppressor genes in our cancer lectures. Those with darker skin have a form of protection against skin cancer, have a greater form of protection against skin cancer. Why is that? Well, the basal cells that are found within the epidermis contain the pigment melanin. And melanin is a very protective factor. It protects our cells. It protects the DNA within our cells. And those that have darker skin have more pigment and therefore more protection, but it doesn't mean that they won't get skin cancer. And melanin is produced by melanocytes that are found in this basal layer of the epidermis. And then now I'd like to remind you of the different layers of the skin. So we have the epidermis, is that top layer here that contains in itself various different layers. They're called the stratum layers. And then we have the dermis beneath that and the subcutaneous layer beneath that. So when I speak about the basal layer, I'm talking about that bottom layer of the epidermis where those melanocytes produce melanin that work to protect our cells' DNA from damage from things such as the sun. And so basal cell carcinoma then is going to be cancer of that basal layer of those basal cells, whereas squamous cell carcinoma, squamous means flat. These are thin, flat cells that look sort of like fish scales, and they're found in the tissue that forms the surface of the skin and all throughout other areas of the body as well. But squamous cell carcinoma then is a type of skin cancer that affects the squamous cells. Okay, so the basal cells at the bottom, more at the bottom, and the squamous cells closer to the top. Now let's have a look at the different types of skin tumors. So what we're going to be doing is talking about not all, but most of these different tumors. We'll start by looking at benign, and then we'll move on to talking about malignant. So we'll look at the first two on the next slide. So we have seborrheic keratosis and actinic keratosis. Let's break down a few of the words here to help us understand why these tumors are named the way that they are. When we say keratosis, this is referring to sort of a horn-like growth on the skin. The term seborrheic relates to the sebaceous glands, which are the small oil-producing glands that are present within the skin. And many of these are located, these glands, close to hair follicles, and they release an oily sebum onto the surface of the skin. Now, the other term to go over is the word actinic. Actinic is a word relating to or denoting light able to cause some sort of photochemical reaction, and we'll see why that's relevant when we talk specifically about this condition. Okay, so seborrheic keratosis is a benign proliferation of the basal cells within the skin, so cutaneous basal cells, that produces this either smooth or warty-like elevated lesion. And the pathogenesis is unknown when we talk about seborrheic keratosis, but these tumors are commonly seen in older people, and there are usually multiples of them. They can be treated with many different remedies in order to get the lesions to sort of just slough off, but they are harmless and, once again, common with age. People will just have one, and if somebody just has one, let's say we have this lesion right here and there's no other seborrheic keratoses nearby, then it can sometimes be mistaken in appearance for a melanoma. So seborrheic keratosis can sometimes be difficult to distinguish from malignant melanoma, even though they're not related and even though there's a huge difference between the two. And so sometimes the lesion actually needs to be biopsied to confirm that it is not cancer. Seborrheic keratosis, also sometimes called SEB-K for short, they are not considered a risk factor for skin cancer. So if somebody has these lesions, they aren't considered a risk factor for the development into cancer. They're also not considered precancerous. They can also appear anywhere on the body. Unlike some lesions, which are only going to be evident in areas where the sun is going to be able to damage the skin. So they can be found anywhere on the body, and in some cases they can look sort of like a scab, which this one sort of does here. Actinic keratosis is a common premalignant lesion. So it's premalignant, which is different than SEB-K, which is not considered premalignant. Actinic keratosis is also known as solar keratosis because these are caused by exposure to UV light. So what we see is that the keratinocytes that produce keratin, which is a protein of the skin, they are proliferating abnormally, and this is because of UV radiation. It's seen the most in those that have fair skin that don't use sun protection. The lesions can appear either kind of rough and scaly, as in this image, or they can be these poorly defined pink to reddish or reddish-brown papules that can be more felt than they can actually be seen. Now, what's important to know about actinic keratosis is that it can progress to squamous cell carcinoma. So if we go back to this slide here, actinic keratosis can progress to squamous cell carcinoma. I use the word papule. A papule, spelled P-A-P-U-L-E, is an elevated lesion that is less than 1 centimeter in size, whereas the term macule, M-A-C-U-L-E, if we use that, we're talking about a flat lesion, so not elevated, a flat lesion that's less than 1 centimeter and in size. And so actinic keratosis can be these papules. In other words, they're elevated, but they're less than 1 centimeter in size. We can see an example here. All right. Now, those that have actinic keratosis, the surrounding area might have what's called telangiectasia, And telangiectasia is a condition in which there are widened venules, so those are tiny veins, that cause these thread-like or red lines or patterns on the skin. They're sometimes known as spider veins because of their fine and web-like appearance. So to repeat myself from earlier, actinic keratosis, it's not skin cancer. It is a benign lesion, but I said that it is considered precancerous, and if left untreated, it can develop into squamous cell carcinoma. But research has shown that people with actinic keratosis have this increased risk of developing other types of skin cancer as well, including basal cell carcinoma and melanoma. And Canadian guidelines, this would be in 2015, recommend that all actinic keratoses be treated, since it's impossible to predict which one of these will actually develop into skin cancer. So where do we see these oftentimes scaly lesions? Well, they can appear on sun-exposed areas, which makes sense because this is a condition that develops from UV radiation. So we're looking at the face, the ear, in people that have a balding scalp that don't wear sunscreen or a hat can have developed these lesions, the backs of the hands, the forearms, the legs, really anywhere that is exposed to the sun, and oftentimes people will have a few present at a time rather than just one. Now moving on to the last two benign tumors that we're going to be talking about in this course, we have keratoancanthoma and nevi. Keratoancanthoma is a benign, self-limiting tumor of squamous cell differentiation arising from the hair follicles. And it usually occurs on sun-damaged skin of older adults, but can also be seen in those that are smokers. Now, histologically or microscopically, it looks like a very well-differentiated squamous cell carcinoma. So keratoancanthoma then looks like a well-differentiated squamous cell carcinoma, but it is not. So it is a tumor of squamous cells, but it is not a cancer. Now, these lesions are interesting because they can resolve spontaneously, which is really why I described it as being a self-limiting tumor. But when these lesions are diagnosed, they are usually removed. That's the optimal approach because of the possibility of malignancy. So in other words, avoidance of this lesion and avoiding it from becoming squamous cell carcinoma is the ideal step. Now moving on to nevi. Nevi are also known as moles. They are these benign, pigmented in some cases or non-pigmented in other cases, lesions that form from melanocytes. Remember, melanocytes produce melanin, and melanocytes we know are found within that basal layer of the epidermis. And these actually begin to form very early on in life, between the ages of 3 and 5. Now, the borders are not irregular, meaning that they're regular. The borders are very regular around, indicating that it's a benign lesion. This here is a pedunculated one, meaning that it has almost like a stalk where it's attached to the skin. Those that have multiple moles or moles that are changing require regular evaluation just to make sure that they don't become cancer. So let's see what we've had a look at so far. We've talked about SEPK, actinic keratosis, keratoancanthoma, and nevi, and now we're going to talk about some different malignancies, and we're going to start by looking at Kaposi sarcoma. Kaposi sarcoma is malignant. It is a vascular malignancy that's associated with immunodeficient states such as AIDS. And it occurs also among transplant recipients that have to take immunosuppressive drugs, so they end up being in this immunosuppressed state or immunodeficient state. And this allows for opportunistic infections, which we know, but it also allows for malignancies such as Kaposi sarcoma. So in terms of appearance, Kaposi sarcoma can look like these purplish brown macules. I used the term macule earlier, but they can develop into plaques and nodules. Those are additional terms commonly used, dermatologic terms that are commonly used. Just to give you an idea, don't worry about the details too much, but plaques are these palpable lesions that are rather large, so they're going to be greater than a centimeter in terms of their diameter. They're palpable, that means they're going to be oftentimes elevated. Sometimes they can be depressed, but in any case you can feel them because there's a difference between that lesion and the skin surface around it. Nodules, on the other hand, when you hear that term, we're talking about a firm papule, really, a firm lesion, but with nodules, they tend to extend deeper into the skin, so extending into the dermis, which is below the epidermis, or even as far as the subcutaneous tissue. And so to give you an example of a nodule, a cyst is an example of a nodule. An example of a plaque could be a psoriasis plaque. In AIDS especially, Kaposi sarcoma can rapidly progress, oftentimes symmetrically over the upper body and the face, even within the oral mucosa. Most people that have Kaposi sarcoma, especially those with AIDS, will have involvement of the lymph nodes in different areas of their body as well. So even though we're talking about Kaposi sarcoma as a skin malignant condition, just be aware that this type of cancer can be found in a variety of different areas of the body, not just within the skin. So Kaposi sarcoma, why does it develop? How does it develop? It's caused by infection with human herpes virus 8. Most people that are infected with human herpes virus 8 actually won't get Kaposi sarcoma, because the immune system can fight it off. So that's why it usually happens in people that have a weaker immune system, such as those that have AIDS or those that are on immunosuppressing drugs. The skin lesions themselves generally don't cause any symptoms, but it can spread to other areas of the body, and when it spreads to other areas of the body, it can cause problems with those organs. And the reason for that is because it can cause bleeding. So if it spreads to areas such as the digestive tract and the lungs, then it can pose problems with the function of those organs. Now we'll talk about two other malignant cancers of the skin being basal cell carcinoma and squamous cell carcinoma. And that reminds me that when we spoke about cancer in previous lectures, we did differentiate between the term sarcoma and the term carcinoma. And then I'd like to just remind you that a carcinoma is a cancer that forms in the skin or tissue cells that line the body's internal organs. So we're relating that carcinoma then to epithelial tissue, whereas a sarcoma grows in the body's connective tissue cells. And we have lots of different connective tissues in the body, including fat and nerves, bones, muscles, cartilage, etc., and also blood vessels. So blood vessels are a type of connective tissue, and that's where the name Kaposi's sarcoma comes from. Starting with basal cell carcinoma, this is the most common skin cancer. Risk factors for the development of basal cell carcinoma include chronic UV light exposure, radiation therapy and radiation exposure, and fair skin, those that have fair skin. This type of cancer originates from basal cells. We talked about basal cells being the cells that make up the deepest layer of the epidermis, where we have those melanocytes and then the production of melanin. Basal cell carcinoma, there's a variety of different oncogenic pathways that exist, but the ones that I want you to be aware of involve mutation of a tumor suppressor gene called TP53. You don't need to know that specific number, but just know that mutation of a tumor suppressor gene occurs. This leads to loss of keratinocyte repair function. Keratinocytes or keratinocytes, remember, are the cells that produce keratin, that is a protein that gives structure to our skin. And so if they become damaged with, let's say, sun exposure, they're unable to repair properly. In addition to that, there's apoptosis resistance. Remember that apoptosis is that pre-programmed cell death. So if a cell is damaged, the DNA within it is damaged, we don't want to reproduce that cell. And so hopefully, if it can't repair itself, it will be pre-programmed to die. So the combination of not being able to repair yourself and then also not being able to die means that this mutated cell, damaged cell, can continue to reproduce itself, leading to the development of cancer, because these cells are full of damaged DNA. In terms of appearance, they usually have a depressed center, as you can see in both images, and these rolled borders. And as the lesion grows, it's very common for it to ulcerate. And when it ulcerates, it then starts to develop crusting around it and becomes very hard or firm to the touch. Now, if left untreated, basal cell lesions, so basal cell carcinoma, can invade surrounding tissues, and it can destroy those tissues in the area. And for this reason, because of their ability to invade and destroy, these are considered malignant. But metastatic spread is very rare with basal cell carcinoma. And the reason for that is because this type of cancer doesn't generally invade blood or lymphatic tissue or lymphatic vessels, and so because of that, it's not able to get to other areas of the body in order to spread. But the thing with basal cell carcinoma is if somebody has a basal cell carcinoma, let's say on their nose, and it's growing large, it is removed, but when it's removed, you're taking away a good amount of the person's nose. Or if it's their face or this region here, if it's a person's face, this of course is not basal cell carcinoma, but if anywhere on the person's face they have this growing basal cell carcinoma and it has to be removed, it's going to be very disfiguring. Now moving on to squamous cell carcinoma, which also has very similar causes with the exposure to the sun or UV light, and those that are fair are more likely than those who are not to get squamous cell carcinoma and basal cell carcinoma. This type of cancer originates from uncontrolled growth of keratinocytes. We talked about keratinocytes with basal cell carcinoma, but when we talk about them with squamous cell carcinoma, we're talking about those that are located not at the basal level, but more superficially when we're looking at the epidermis. And it's the second most common human cancer. So you can see then that basal cell carcinoma and squamous cell carcinoma are very common when we talk about cancers. Now remember that actinic keratosis is a benign tumor that is a precursor to the development of squamous cell carcinoma. They do have the tendency to bleed. You can see that they will form these nodules, and they can take on other forms as well, but they can invade surrounding tissue, and when they are removed can be very disfiguring, just like basal cell carcinoma, but they don't tend to invade the blood and lymphatic vessels, and therefore are not more rare for them to actually spread to other areas of the body. But of the two of these, which collectively, again, are called non-melanoma skin cancers, of these two, it is squamous cell carcinoma that is more likely to spread than basal cell carcinoma, even though overall spread is considered to be rare. One of the difficult jobs of healthcare providers is distinguishing between a benign versus a malignant lesion on the skin when we compare a nevi or a mole to that of malignant melanoma. So let's first elaborate on what malignant melanoma is, because we've already talked about nevi or moles. Malignant melanoma is a malignant tumor of the skin that originates from melanocytes. So really the transformation of melanocytes, which we know are the cells that synthesize the pigment melanin, and they become cancerous. Discovering melanoma at an early stage can drastically increase a person's 5-year survival. So far what we've talked about is cancer of the basal cells of the epidermis. We've talked about cancer of the squamous cells of the epidermis, and now we're talking about cancer of the melanocytes specifically that are found within that basal layer of the skin. What you can see on the screen in front of you is some of the important variables that are used when analyzing a mole or any skin lesion to ensure that it is benign versus malignant. And of course, actual biopsy and microscopic evaluation would be really the only way, but visual inspection can be very accurate, especially with the trained eye. So we can see that one of the things that you're going to look for is the presence of asymmetry. And so when we look at this benign mole, we can see that it's symmetrical, but when you look at this malignant melanoma, you can see that it is very asymmetrical in its appearance. Okay, when you look at symmetry on either side and throughout. The border as well. Do the borders have nice even edges or very uneven edges, as they can with malignant melanoma? The next variable has to do with the color. When we're looking at a benign mole, generally one shade seen throughout, but with malignant melanoma there can be different shades. And you can see it's lighter over here and darker over here. And this can be tricky when you're looking at really all of these variables, when you're looking at those seborrheic keratosis that I said can resemble malignant melanoma and sometimes hard to distinguish between the two, and that's because it can have these asymmetrical borders, uneven edges, 2 or more shades, and even be larger than most moles should be. And so that leads us then to our next variable, which is the diameter, generally smaller than 6 millimeters versus a malignant melanoma that is generally larger than that. Another variable to add into this is E, and E for evolving, and that would be watching to see, is this mole actually changing? If somebody has what is suspected to be a mole, is it changing over time? And monitoring then is going to be very important. Now we're going to look at staging for melanoma. Prognosis of malignant melanoma is dependent on the staging of melanoma, and staging also will then determine the treatment method. And the cancer stage in the case of malignant melanoma will describe the tumor size and also tell whether or not it has spread beyond the place where it initially began to grow. So we're going to look at 2 different scales. One is Clark's levels, and then in a moment we'll look at the Breslow scale. So when somebody is diagnosed with malignant melanoma, they can be given a level, and the level under this Clark's level can indicate the extent that that melanoma has invaded the tissue in the area. And so we have levels 1 through 5, and if you read through these, you'll see that as you progress from 1 through 5, you have an increase in the extent of tissue invasion. So with level 1, it's only involving that top layer of skin, the epidermis, where, remember, those melanocytes where the melanoma originates is going to be found within that basal layer. But level 2, this involves not only the epidermis, but the layer of skin beneath it. So we're talking about the upper part of the dermis. With level 3, we're extending down, invading into the middle layer of the dermis rather. And then level 4, we're getting deeper into that dermal tissue. Those that have level 5, there's been invasion of the subcutaneous fat, or the subcutaneous layer beneath the dermis, also known as the hypodermis. We also have Breslow's scale that describes the depth or thickness, and this really indicates the person's 5-year survival rate. So if the melanoma is less than 1.5 millimeters in size, there's a 93% survival. Once you get up to 1.5 to 3.5 millimeters, 85% survival, and then greater than 3.5 millimeters, which when you think about it really isn't that big in the grand scheme of things, the 5-year survival rate drops to 37%. So all of these variables can be taken into account when an oncologist would be actually staging a person's melanoma. And then, of course, there's always that consideration that when we think back to talking about cancer in earlier courses, earlier lectures, when you can have anywhere from cancer being in situ, so it's in place, versus cancer that has started to invade, versus cancer that has metastasized. And that's where we're getting into stage 4 cancer, where survival goes down quite substantially. And combining your Clark's levels and your Breslow's scale can be used again to stage a person's cancer from being stage 0 to stage 4. So really in situ to metastasized. This is an additional image to show you that we have the Breslow scale here showing you the depth of invasion. And then we had Clark's levels of invasion 1 through 5 to show you, or to describe to what level of the skin this cancer has grown and invaded. And so this tumor here, this malignant melanoma, it would be described then as having a depth of invasion of about 3.3 millimeters and would be a Clark level of 4. Which, going back to this slide, Clark level of 4 was invading the deeper dermal tissue, which you can see here. So the particular part of the dermis is the deeper layer of the dermis. So how is this actually determined? Well, you're going to have the tumor biopsied, but they'll also take some of the healthy skin around it. So here representing the tumor and the healthy skin around it so that you can see the level of invasion. Melanoma can metastasize to almost every major organ and tissue in the body. Melanoma that has spread to other parts of the body, so distant metastases such as the lungs, the liver, and the brain, have a much poorer prognosis than if somebody had metastasis to an area such as the skin or just to lymph nodes. Now we're going to move on to a case study on malignant melanoma. So we have a 39-year-old male that has very fair skin. He has a history of numerous nevi or moles since childhood. He presents with a large, dark, irregularly shaped skin lesion on his mid-back. He's a gym teacher, and he has a positive family history of dysplastic nevus syndrome. In short, when we talk about dysplastic nevi, we're talking about atypical nevi. And these are generally acquired. They take on a larger size than your normal moles do, and they're usually irregular in terms of their pigmentation. They can have poorly defined borders, and they need to be watched closely. Those that have multiple atypical moles and may also have your common moles as well are thought to have this dysplastic nevus syndrome. Upon physical examination, a 5 millimeter irregularly shaped darker lesion was found in the mid-back. He has obvious moderate sun damage to UV exposed regions such as the face, neck, chest, and back. His skin has numerous moles and freckles. The conjunctiva and retina of the eye do not have any obvious lesions. The eye actually has melanin-producing cells within it as well, so you can get melanin of the eye. There are no supraclavicular, cervical, or axillary adenopathy present. Supraclavicular is, we have these lymph nodes that would be found above the clavicle, in the neck, and in the armpits. And if there is spread from the melanoma to the lymph nodes, it's possible that the lymph nodes can be palpated. So adenopathy is a disease of the lymph nodes. Lungs were clear to both auscultation and percussion, no liver enlargement, and his strength and reflexes were normal, equal, and bilateral as part of this overall physical assessment. So in this case, a biopsy was done of the lesion, and he was diagnosed with superficial spreading melanoma. This is the most common type of melanoma. It is a skin cancer that grows horizontally across the top layer of skin before moving into the deeper layers. That's why it's called superficial spreading. And of all melanomas, superficial spreading melanoma would be about 70% of these cases. And his Clark level is 4, so that deeper part of the dermis, and his Breslow score 2.2, so you can cross-reference with these diagrams. But what does a Breslow score of 2.2 millimeters mean in terms of percentage of survival? So if we go back to our scale, this is a repeat slide, you can see he would fall in this category here where he's given about an 85% chance of survival. But of course, there are going to be other variables in play as well. A wide local excision was done on the lesion, and they did a biopsy of the sentinel lymph node. The sentinel lymph nodes are really the first lymph node to which cancer cells are most likely to spread from a primary tumor. The medial border showed cancer cells were present, so cancer was present and inflammatory changes as well. Lymphoscintigraphy was completed. Lymphoscintigraphy helps evaluate the body's lymphatic system for disease using small amounts of radioactive materials that are called radiotracers that can be injected into the skin to evaluate the lymphatic system. And the idea would be to try to identify whether or not there are any hot spots or areas where maybe the cancer has spread. And so in his case, there was one hot spot identified in the right armpit, but upon lymph node biopsy, it was negative. So of course, that's a really good sign. Biopsy, that is, of that sentinel lymph node. Okay, so that really is the end of the lecture on melanoma, but I want to finish off by talking to you a little bit about sunscreen. And you know the importance, but I wanted to educate you a little bit more. So you know that sunscreen will have an SPF factor, but what exactly does that mean? Well, SPF stands for sun protective factor or sun protection factor and refers to the theoretical amount of time that you can stay out in the sun without getting sunburned. So for example, an SPF of 15 would allow you to stay in the sun for 15 times longer than you could without any form of protection. A lot of people assume that an SPF rating of 60 would provide double the protection than an SPF of 30. But as you can see by this image, that is not true at all. You can see that an SPF of 5, what could happen, the protection that you get with the skin compared to 10, 15, but when you look at 30 to 60, there doesn't appear to be much of a difference. So studies over the years have shown that sunscreen with an SPF of 15 blocks out about 93% of UV rays, 30 blocks out about 97% of UVB rays, and an SPF of 50 blocks out 98% of UV rays. Above that, really 30 and above, there's not that much of a difference. So I've seen some people buy or find somehow SPF of 90, and they're not going to be getting any more protection than they would really from SPF 50. The bottom line is that an SPF above 30 is really increased. The increased protection is really minimal, but an SPF of 30 provides a lot of protection in itself. That's the end of today's lecture. Thank you for listening.